like a huge discussion. Oh, yeah. Teamwork and leadership is just kind of a huge discussion in general, and we can take it in whatever direction we want. So I'm gonna start with by sharing my screen, and then we'll go through some slides, and then after we get through like the first chunk of slides, then I can take a view back and try and define exactly where we want the rest of the lecture to go. Okay, cool. Start with this cheeky little slide. Also, I don't like wear button-ups in my day-to-day. I was suit shopping today. I was doing a very like attending level thing. One of the like older attending, sort of a mentor of mine at my current shop, was like giving me this speech like a month ago. It's like, when you reach a certain station in life, you should own a casual suit. And I like hadn't really ever thought about that kind of thing. So he sent me in a direction. So I've just purchased a casual suit for myself. I will never be wearing it at any of the events that I see you guys at, unless somehow we all meet in different contexts. All right, here's let's talk about teamwork. We're going to start with a couple of stories from the 70s. So this is the story of 1972 Eastern Airlines Flight 401. Some folks may or may not be familiar, depending on how closely you've studied team dynamics. Second disclaimer. I live on Flatbush Avenue in Brooklyn. You will hear sirens. You will probably hear people yelling or fighting outside. It's New York, baby. I apologize if we get interrupted. Okay, Eastern Airlines Flight 401. So this flight was bound for Miami, and at they're approaching, and they put their landing gear down, and the light for the front landing gear doesn't light up. This turns out to just be like a burned out bulb, but there was no way for the crew to know it at the time. So the co-pilot goes down to like visually check on the landing gear and do a manual lowering of the landing gear if that ends up being necessary. The pilot just sets everything to cruise control, and they climb to 2,000 feet, and they cruise control at 2K. And at some point during communication exchanges, the pilot and the co-pilot are just kind of like talking and intently trying to figure out this landing gear situation. The pilot nudges the yoke, the joystick for the plane, and which triggers a conversion from cruise control to manual mode, and the plane starts to slowly descend. And it's like almost imperceptible. No one really notices that it's happening. And because I think the yoke that was nudged was the co-pilot's seat, eventually like an altitude alarm goes off, but it's going off like in the co-pilot's headset, so it's kind of hard. Like the captain can't really tell. And there's the black box, recovered after the incident, picks up this exchange over the radio where the pilot and the co-pilot are saying like we did something to the altitude, like what? We're still at 2,000 feet, right? And there's this moment where they're kind of brought back out of this focus on the landing gear, and then they crash into the Everglades, and half the people in the plane die, including the co-pilot and the pilot. Obviously, an absolutely terrible event, but that wasn't the only rough event in the 70s, because in 1977, there was this bomb threat at, I can't remember what airport, but a bunch of flights get redirected from that airport destination to this tiny airstrip in Los Rodeos. And this airstrip is not really designed for commercial jets, but so there's all these like big Boeing passenger jets using this airstrip now, and the air traffic controllers don't really know how to handle this kind of volume, and they're trying to like jigsaw and Tetris these planes around. And it's a clear day in this photograph, uh, but this is actually like an incredibly foggy day. Like you can't even see, you know, halfway down the runway because the fog is so thick. So there's this Dutch airline, KLM, that goes in taxis at the very end. They're waiting to take off, and the there's a Pan American flight that's taxiing down the runway. The air traffic controllers have told them just taxi down the runway and then turn left at like the third runway, and then you'll use that to taxi around. So they're taxiing down the runway, going the opposite direction that a plane that's taking off would be going. And the KLM flight's like waiting for approval to start. And because there's some non-standardized language being used by the air traffic controllers, and because there are no like readback systems in place, And because the KLM pilot just kind of wants to go, um, they sort of interpret something they've heard as that you're now okay to take off, and they start to take off. So Pan American is taxiing down one direction, KLM's coming the other direction. By the time like they can see each other, KLM is already at takeoff speed. The Pan American jet starts to turn. The KLM jet sees them and tries to climb, and they get the nose above the plane, but their wing clips, basically slices the Pan American plane in half. KLM wing gets totally destroyed. It flies for 150 feet and then crashes and explodes. Everyone on the KLM flight dies, and half the people on the Pan American flight die. Um, this is I think it's either actual footage or just like a very very good for the era CG of what that collision looked like. So I mean the crazy thing about this like miscommunication is the co-pilot of the KLM flight that took off and like and effectively sliced the Pan Am plane in two. The co-pilot said like, Are you sure that they said that we should go? I think that we're not supposed to actually go." And the pilots and the lead pilot said, "No, no, no. I think we need to do it." But that lead pilot was he was a flight instructor for KLM. He had actually done like the instructor certifications for I think one of the pilots on the other Pan Am flight like within a month before. Like so and there's this like crazy bit of news where like when KLM found out about this incident, they're like, "Oh my God, we need to, do an investigation. Let's put," and the guy that they select to like lead the investigation is the fucking pilot that died, that made the mistake in the first place. Because they're like, "Oh, he's the most senior person. He should be doing it." So all that to say, there's like these hierarchy things where people were like really respecting someone um, with a lot of experience, but not wanting to question that authority. They just sort of went ahead with this unsafe plan. Um, Things have gotten better when it comes to airplane crashes since the 70s. This is like at the very far left of this graph. You can see 1970, and to interpret it, what's going to be the important part of this lecture is the human factors, the green bars. It's just the number of accidents that had occurred where the cause of the accident was attributed to human factors. And you see this number, it's kind of like, because the bars are stacked, it's hard to track it, but it's kind of staying steady for most of this time period until like really recent history, like 20 after 2010 is like really when the bars start getting small. At least it seems that way. So you're like, oh, maybe things haven't like has taken a long time to change. But you actually look at how many flights have been flown since that time, and the number of accidents actually stayed steady as like the number of flights have risen a lot. So proportionately speaking, after the 70s, people were actually doing a lot better. Um, and the question is, what really changed there? Uh, After these collisions in the 70s, the airline industry started to look into human factors that were contributing to these disasters. And they started to, they basically created this world of team dynamics and human factors research, which is the lens by which people who are interested in this topic tend to look at high risk events and leadership and team dynamic errors that lead to them, and high risk events and team dynamic traits and leadership traits that tend to lead to success. Why the fuck are we talking about airplanes right now? This is, a wilderness medicine lecture. Like, why am I doing this whole big thing? Um, a lot of the concepts that I want to talk about during this lecture are derived from the airline industry. So after the 70s, the airline industry developed this whole way of looking at team dynamics called crew resource management. And it's been adapted into the operating room or into general healthcare environments. It's used by firefighters and military. There are various adaptations that various government agencies have had their hands in architecting for different fields. And if you're going to pick a gold standard across the United States for team dynamics, this is a pretty good model for it. Um, yeah, Eric was saying like airline industry and medicine have a long historical overlap with safety mitigation. Here's the other thing to think about. Like this happened in the 70s, and airplanes are new technology-ish. They're certainly newer than like human beings trying to practice medicine on each other. But we didn't really take safety and human factors and patient safety that seriously for a really long time. And we're not the industry that pushed paying very close attention to the way that teams work, the way that people communicate, the way that people prevent accidents from happening. The airline industry did, a younger industry than healthcare. What this means is that when it's your life as the pilot, you take it a lot more seriously than when it's just some fucking patient's life. You know? Like we should sort of be a little bit ashamed in medicine of how long it took us to get this serious into patient safety principles because it's, oh, it's just you're just not that driven to be that perfect when it's not your own life on the line. Little editorial on that. And now we can kind of get back to the meat of this lecture, which is supposed to be team dynamics and leadership. So it means so many different things and so many different concepts. And folks on this call have been like on backpacking trips or climbing trips, you've been in high risk situations or just uncomfortable situations with people where you had to communicate and make things happen. And there's so many different leadership models. The National Outdoor Leadership School, Knowles, had this like incredible leadership curriculum, and all their instructors just get this really good like um, education on how to lead and resolve conflict. I'm gonna focus on leadership and team dynamics in a really specific context, and it's the context in which I work the most. Because I do some stuff with New Jersey Search and Rescue, and I like, my personal time going backpacking trips. But really, when it comes to like crisis resuscitation and team dynamics, that's for me happening in critical resuscitations in the trauma bay and our resus areas. So the type of teamwork that I want to focus on today, um, is going to be the type of teamwork that occurs when a really sick patient is in front of you. And that can be in a trauma bay or that can be in a pre-hospital setting. And you have a team of several people to coordinate. And you want to get through a series of very complex tasks and you want to do them without error. Um, and in order to do that, I want to build this lecture around the structure of the team steps model of leadership. So, Team Steps is it's the brand name for this version of a teamwork and leadership model that came from the airlines and now has ended up in healthcare. And it was like a joint effort from the Department of Health and the Department of Defense. There's a few government agencies that are involved in it. It gets taught at a lot of hospitals and medical settings nationally, with this like, bundle of like pre-made lectures and stuff, which frankly, I looked through the material and like the lectures are pretty crappy, though I think the ideas are pretty good. And the folks that contributed to this, the researchers, are all like huge names in the field of human factors research. So I like the way they broke it down into four domains, and we're just going to touch on each of these domains. I'm going to share like a couple of thoughts about how you can optimize communication, team leadership, situation monitoring, and mutual support, the four domains of team steps in your healthcare situations. And then please like jump in with comments, questions. We can make this a discussion. We can also come back to this and like discuss it after I'm done if that's easier for folks. Any of these formats will work. It's only four domains, so it shouldn't be that hard to memorize. All right, let's talk a little bit about communication in high risk situations. Has anyone heard of I'm gonna like pull up these pictures so I can see all your faces. Anyone ever heard of Shisa Konko before? Does that word mean anything? It's this Japanese practice. It like literally when translated it means point and call. It's the standardized system by which train operators for the Japanese Shinkansen, they're like bullet train, are supposed to confirm everything they see and everything that they hear. So, when because these trains travel at like super high speeds and they basically just take off like a shot, everything kind of needs to be, uh, doors need to be closed, things need to be working correctly before they initiate. So there's these guys on the platform that just like look and point and just make sure that the train is lined up where it's supposed to be and that the doors are closed. And it's a it's a high stress task in that the consequences are high, but it's a pretty simple task. You just can't fuck it up. This is one of their educational pamphlets. Look at an object, point at it, raise your right hand to your ear, and bring your hand down. This makes a link between what you're saying and what you're acknowledging and what you're seeing, and everyone knows what you're pointing at. The reason I put this up here is that you will all be, if you have not yet been, involved in medical situations where lots of people are in the room. People cannot hear each other very well. People do not know who is being addressed by certain things. When you want to talk to someone, it is totally appropriate to gently put your hand on their shoulder, make physical contact, or point with like four fingers so it's not like that really accusatory single finger point, or gesture, or somehow make a visual connection with the person with eye contact or however you do, so that everybody knows what's actually happening. When I give commands to my team during a trauma or during critical resuscitation, I have long enough arms that I'm literally just like tapping people on the shoulder and like if I know their name, using their name, but at the very least I can like make that contact. And there's no question about who I have just given that instruction to. And and if they're following these like team steps principles, they should be closing the loop on any communication that I give them. Closed loop communication, I'm assuming, is something that folks are familiar with. Yes? Cool. This is also a like crew resource management aviation strategy that has made it into healthcare in the team steps model. Closed loop communication. Okay. She's a Conco, point and call. A second concept I want to include in our communication discussion is the idea of the quiet cockpit. So in aviation, there are certain critical moments, such as takeoff and landing, where the cockpit should be quiet of any contamination. It's actually, I think, referred to as a sterile cockpit, where any conversation, communication that's not related to the critical task at hand is considered a contaminant of the cockpit space. You want to maintain a sterile cockpit during the critical moments of a resuscitation. This may be airway maneuvers. If you've decided to intubate a patient and you want like everyone to be focusing on that task, you can call for like a sterile cockpit type environment. And just saying sterile cockpit is going to confuse a lot of people. But the trying to maintain a quiet sphere during critical moments is something that everybody can participate in if they're aware of it. I mean, most folks on this call are not the attending physicians leading these resuscitations yet. Your team members, and understanding the importance of this concept is going to make you a better team member. One thing that I did a lot in residency, if there was like, a co-resident of mine was leading a resuscitation, was I would kind of like lurk and scurry around and just sort of like shut people up that were in the background. There would be like, a paramedic who was done signing out and just sitting in the back and gabbing with his buddy. I would like sort of usher them out of the room or ask them to be quiet. A couple of like, medical students that may not have the presence of mind to know that their conversation is distracting. I would get them to calm down, even like co-attendings or co-residents. Maintaining a quiet cockpit helps everybody think, helps everybody communicate, and as the volume rises and rises and rises, it becomes very hard for everybody to focus on a critical task. Um, all right, moving on from the communication sphere, which is a huge bundle, but that's a couple of things to get your thoughts into a framework. Here's the team leadership domain of team steps. What is a good leader? I mean, there's a lot of we all have kind of our own image of what the standard leader should be, what the traits of a strong leader are. There's probably some variation between these. I think a lot of us have done enough thinking about what a good leader looks like that you don't need to list out like every characteristic, but just to have something to reference some literature, I'm going to pull from this manual called Trauma Team Dynamics, which has some gold in it. It's a pretty thick read, but there are a couple of good pieces to it. And this quote I felt was helpful just for having a definition. An effective leader stands back and manages the team, avoids authority gradients by listening to and accepting input from the team, and demonstrates prompt and firm decision making. The second point about accepting input is one that kind of needs to be established. Um, if you work with a team for a long time, you can set a precedent of being someone who accepts input, and that makes for a healthy team dynamic. If it's a swarm team, like a lot of our teams are in the ER, where like, you're kind of doing your own thing, all of a sudden someone gets really sick and a bunch of people are in the room and not everybody knows each other, or you haven't all been working together on the same shift for a long time. The timeline is kind of shortened there for you to want to be able to establish that you're willing to accept input. But the more you can think about yourself as someone who accepts input, the more your micro behaviors will hopefully encourage folks to speak up if they have a concern and then take those concerns seriously. In contrast to the second flight that we talked about, where the co-pilot's concerns were not taken seriously. Um, in terms of the stands back and manages the team, this is, a kind of a metaphor, but it's actually literally very good advice in resuscitations. If you're leading one, try not to touch the patient. I actually don't put gloves on when I lead traumas. I just kind of have them in my hand in case I need them. Keeps me from touching the patient and helps me like stand back. And uh, there's even, something to be said about what sort of posture you take when you stand back. I when I when I started running traumas in residency, I started behaving like this space captain in this like sci-fi series that I read when I was in middle school, Honor Harrington. This like, this captain, she has like all of these classic leadership traits that you'd look for. So I kind of imagined myself standing the way that she does, as described in the first chapter of the first book of the series. And this is like a shoulder, like a feet shoulder width apart, hands clasped behind the back. Like she's very conscious of it because she's like a woman on a battleship. And she like even in the future, there's still these, these gender stereotypes that she needs to overcome. So I kind of try to posture myself like Honor Harrington. All right, situation monitoring. This is probably some of my favorite stuff to talk about. This is also called situational awareness or situation awareness. There's this researcher named Micah Ensley who published all of these like really dense articles for the Air Force where she defines situation awareness for pilots and like it sort of breaks down like the actual psychology of exactly how a pilot like gathers information, formulates it, and then turns it into action. And almost does it in sort of a computerized way. This is a little clip from her paper where she like describes situation awareness for the first time. There's like three levels of it. There's like where you just perceive the data and the elements of the environment. Level two is where you comprehend what all that data means, and level three is where you start to predict what's going to happen next. This is the skill of the resuscitationist. You need to bring in all this medical information, formulate it, and then you need to guess what's about to happen next. If you're not staying ahead of the patient's physiology, then all you're doing is playing catch up with the things that happen. Predicting what's going to happen next, predicting when they're going to become more hypotensive or hypoxic, predicting how things are going to go is sort of like the higher level skill that makes you capable of turning around patients who are on their path to death. So situation awareness is something that the resuscitationist leader needs to know about, but it's also something that the leader needs to share with the room. Everybody in the room should understand what the condition of the patient is, how we got there, and where we are trying to go relative to the direction this patient's headed. That way that people are sort of empowered to make their own decisions in terms of priority. Maybe there's like three tasks you give someone, something changes. If the person you've given the task to knows what the biggest goal is, the priority is 1, 2, 3 for the patient, they can prioritize in their head which tasks to do before the other ones, which of their, the folks they're working with, they're able to get in the way of in order to do a task for which they should stand back and allow other folks to do the task. Um, Bestowing situation awareness on the team is the responsibility of the team leader. And I'm not saying that you need to summarize what's happening in the resuscitation every 2 minutes, but I am saying that there are a few key moments in every resuscitation that you should think now might be a good time to summarize the state of the case right now and what our goals are. Those 3 moments are one, when there's chaos, when things are falling apart, when people are shouting, when things are loud, when everything is kind of getting out of hand. Um, and you want to cool the room down and focus folks, this is a good opportunity to provide an update or to provide a sit rep, a situation assessment, and a plan for everybody. Um, as a team leader, you should be like raising your hand, trying to make yourself as physically big as possible, raising your voice in order to calm the rest of the room down. One like utterance of the word quiet sometimes goes a long way as long as you say it with confidence. The way that you like socially run a room is that's a skill that is going to take all of residency and all your whole career. And some of you probably already have it, and some of you will get it eventually. Um, Bringing order to chaos is one of the 3 moments. The other moment is when things change, when the condition of a patient changes for the worse, when all of a sudden they become hypoxic, all of a sudden they become hypotensive, all of a sudden you get handed an EKG that shows a STEMI and you didn't realize that you were in the cardiogenic shock pathway before. When these things happen, this is a great time to reorient everybody in the room and provide a situation update. And then the third situation in which a situational awareness update is beneficial for your team is when you're going to do a critical procedure. So if you're sedating for an airway, this is the classic one for emergency medicine. As you prepare for that, it's good to get everybody on the same page prior. And that will also help encourage the sterile cockpit environment that you want for an airway intervention. Last category, mutual support. This is not that much more complicated than telling everybody that they're doing a great job. It is very, very hard to do complex tasks. It's very, very hard to do medicine, and it's very scary. And will always be people in the room that are as scared or more scared than you are. And there will always be people in the room that are sort of teetering on the edge of being too overwhelmed with anxiety to perform their jobs well. Giving positive reinforcement in the moment helps enable people to be better at their job. I am not saying to give exclusively good feedback in the long term. In fact, a good leader gives critical feedback in a timely manner. If you're leading a team over the course of a shift and you get through a resuscitation and someone really needs to improve their behavior or the manner in which they did something, or there's a big deficit, that should be addressed pretty quickly. If you just let these things sit, then the team suffers for it, but not necessarily in the moment of the critical resuscitation that we're talking about. That's a good moment for exclusively positive feedback, very clear, direct, redirective feedback if someone's doing something wrong, but not to like stop and have a whole conversation about how this is a pattern of behavior and that when they need to improve it. In the moment of something critical, just find good things to say. Congratulate the chest compressors. Congratulate the folks who did a roll very quickly. Congratulate the RN for getting the IV. Congratulate the resident who's managing the airway. Get everybody feeling like they're effective so they can be effective. What thoughts do folks have on these four spheres of teamwork, team dynamics? Have folks been exposed to any of these ideas before? Do folks have other personal experiences they want to share that sort of highlight the importance of one of these domains? I'm going to open it up because we got time.
I just had one thought that popped into my head on the situation monitoring part when you were talking about summaries. I found it's incredibly helpful for anyone in those situations to like, if there's a big change, even if we don't do a full summary moment because we need to deal with it, to just be like, hey, this changed. And a good example of that is we had a patient with a pretty awful GI bleed. And at one point, my attending just like froze and was like, he's peri code. We need airway, we need this, and we need it now. And it was like everyone in the room was able to suddenly change. And she didn't have to say any more than, he's peri code. I need you this, I need this. And it was done. And it was
Mm.
really nice to see like a short version of that summary that helped us all like have that moment of situation like, oh crap, I was really into the central line I was doing or whatever, but now I need to figure this out.
That's really good. And um, there's a strategy of communication called fly by voice, which this kind of it's sort of a complementary strategy whereby like you kind of speak out loud as you're thinking through the process or as you're observing things. And if your attending is watching things happen and they recognize that this person is peri code, like verbalizing that to the room starts moving things in the right direction and recruits more brains. The most terrifying thing I learned when I was looking through all of these old examples of aviation disasters was that the most common verbal exchange in the 2 minutes leading up to a disastrous crash is silence. People just stop talking to each other and lock up and freeze. And then, like, within 2 minutes, the plane crashes. When people stop talking and stop, like, trying to share what they're thinking and what they think the next goal should be, um, then things start to like deteriorate and everybody's anxiety takes over. Everyone becomes isolated and they don't share their mental models, and then you can't move forward as a team. So I love that your attending was like very verbal about what was like in their head and kind of kept the room talking. That's great.
I had a example question for you, Ryan. So I was on a sub-I and saw a situation unfold where, it was a trauma. So it was a trauma patient, penetrating trauma patient. It was a trauma chief resident. It was an ED attending, and an anesthesia attending.
Mm,
And the patient,
love
they
that.
decide they're gonna convert the trauma bay to an OR, as they, convert to an OR. And it's the classic too many cooks situation. And in that situation, I feel like in a lot of other situations, it's really hard for the support folks, nurses, techs, whomever is there, to decide who's in charge. Because, okay, well, anesthesia, are they in charge because they're at head of bed and we're converting this into an OR and they should be in charge of resuscitating the patient in order to bridge them to their surgery? Is this the ED because, well, we're in the ED? Is this the trauma chief resident because this is a trauma patient? Um, in situations like that, I've often seen a lot of like butting of heads, and I think that the academic environment like certainly contributes to that. I think at community shops this looks quite different. But I was curious if you've noted any like team dynamics that seem to work well in that situation, or ways that there can be a discussion about who indeed is the leader, or if there's a division of powers.
I'm glad you brought up this specific circumstance. It's actually part of what inspired the architecture of this lecture in the first place. I first lectured on this topic while I was a PGY4 in residency. Um, our our residency trauma system um, had a established hierarchy at the top of which were both the ER attending and the trauma surgery attending. So our pyramid ended in 2 points, which is not a pyramid, nor is that an effective leadership strategy if there's any like disconnect between the two people that they can't resolve quickly. That's actually how things are at my current shop too. I don't love it. The most standard format for trauma evaluation at level one trauma centers across the country is for the trauma surgery department to run it. In wide, far and wide, the emergency medicine attending is just an airway operator when it comes to trauma. In most of these like high performing trauma centers. In fact, like as an example, Legacy Emmanuel is the other level one in Portland besides OHSU. And they see way more serious trauma volume than OHSU does. And the for their like high trauma activations, an anesthesiologist comes down, the trauma attending comes down, and the surgical ICU nurses come down. They all just run it all in the trauma bays of the ER, and the ER doesn't even do anything. Like they're not even involved. Like the lower acuity traumas, the ER attending comes over. Um, I don't know if I love running trauma, so I'm glad I get to work someplace where I'm involved in it. Um, but I recognize that the like this dual-headed structure is problematic when folks can't resolve things. And the right role always sort of seems to be a moving target. I'll tell you what experiences I've had recently that have sort of influenced what I see as my role. So in the emergency department, some it's ER nurses, it's the ER environment, it's ER equipment, it's ER staff. The ER attending knows where everybody is and what where the things are. If one person is going to be calling out instructions to folks, that's the person to do it. It's not the trauma surgery attending. It's not the anesthesiology attending. It's not someone who is going to call out into the ether that they want fentanyl or that they want ketamine or etomidate. It's someone who can look directly at a specific person who they know knows how to get into the Pyxis, who they know they have not already directed to do something else, and delegate that task. Now, that's usually how it works once specialists have started getting involved in my resuscitations. I tend to like try to invite people in. I have a refractory VFib. I do get a lot of support from our cardiology department, and I'll get like an electrophysiologist down there, like fucking with the patient's, implanted cardio defibrillator with their laptop, like at the bedside. It's amazing. But they're the heart person, and I'm running the rest of the room and doing the meds. We intubated a 19-month-old croup a month ago, which absolutely had me pooping myself. But I like called down the pediatric ICU attending to kind of be in the corner and a pediatric anesthesiologist to stand behind the PEM fellow that I had intubating. Because like I wasn't going to like have anything that smart about how to troubleshoot the pediatric airway relative to what they could do. But I like kind of defied my mental model involved putting these people into a role for their task and maintaining control of the entire room. This is something I've been practicing on doing more and more, but it's really hard to do because no one's going to give you control of the room. If someone senses that you're losing control of it, that you don't, you're not on top of what needs to happen next, they'll try to take over in a manner that they think is going to be more effective. And their anxiety is going to drive it. So the trauma surgeon will just start calling out for things that they want to have happen without delegating them. Uh, it makes the task really complex. And in order to like successfully run a room of people who are co-professionals and who may or may not themselves have a good model of what teamwork should look like in a room, you have to anticipate every single person's need. So when you know that before the trauma surgeon says they want the chest tube, you need to be delegating people to get the chest tube supplies at the bedside on the relevant side and delegating the RN to get the relevant sedation medications. You need to be on top of everything. And you need to sort of like preempt everything because as soon as you fall behind, then other people have the ability to lose control of the room for you. I'm I'm describing a very complex and really difficult set of tasks, and it's because it is. And while I'm, presenting this as standard behavior in medicine, y'all have been around enough of these critical situations at this point where you probably have seen like it doesn't actually happen that well that often. a lot of these resuscitations, the really, really bad ones, end up feeling kind of bad to people that are in them. It's a really tough task to make them feel good. It's an extremely worthwhile task to make them feel good. One, because you can improve outcomes, but two, there are some of these resuscitations where you're just not like, you're not getting this person back. It's like game over no matter what you do. But you can get this team to leave feeling like they put in a professional effort and that they did not feel antagonized by the people that they're working side by side with in the pursuit of trying to resuscitate this patient. That's a very worthwhile goal. And that's why I like, I do all this reading on like weird, complex, like leadership thought principles and why we're like having this lecture here. I don't know if I have anything more specific to contribute than that, Eric. I mean, it's like, every situation's kind of different, but that's what those experiences for me are what resonated when you sort of shared that story. I'm sorry you were in that situation. But you learn from the bad stuff too.
Thank goodness I was just a med student, so I was pretty quickly ushered out and thankfully didn't have to be subject to too much disagreement. But yeah, it's definitely like viscerally uncomfortable when multiple people are kind of trying to like fight for control of a situation that they feel like everyone else is getting out of control.
Yeah. Yeah.
I feel like the only teams I've ever seen do it well are the ones where the trauma team and the ER team train together. Like they do their ATLS classes together, or they
Yeah.
do like their trauma, like big trauma training days together. And so that like the trauma surgeon attending has been standing next to the ER attending before, or at least knows the residents. And then like the vibes are just better. Everyone's just nicer because they've done this training together and they know everyone learned the same thing.
Yeah. Yeah. An overall professional environment and a professional culture in an institution can make a huge difference here. One of my friends from residency was a surgery resident. She's now graduated. She finished her trauma surgery fellowship at Harborview, and she's back here in Brooklyn. And now we work at the same hospital. And it's awesome whenever Lauren's on at the same time because we've like, I don't know, like we're buddies. We've been doing this for together for a long time. And we in general have a pretty good relationship with our surgeons at our hospital. So I feel lucky for that. That was not the case at the place where I went to residency, but that did expose me to a lot of opportunities to both participate in and witness effective and ineffective conflict resolution strategies. And when you're picking the place to train, don't pick the easiest place to work because you want to be exposed to the tough situations so that, when you're actually making the calls, you've sort of been there before. And so I appreciated that aspect of the trauma surgery and ER relationship of Elmhurst Hospital Center if I didn't necessarily appreciate the vibe of the trauma bay all the time. Any other thoughts, feelings, stories? I can put our little map up again so people have their domains in case it's helpful. Anyone have any like, ooh, Haley, talk.
Oh, no, I was just, I guess, gonna ask sort of about, I mean, like I'm nearing the end of the med student role, but I feel like I'm gonna feel this way as an intern as well. Where like if you are sort of the, lowest in the group of, having seniority, and you see things like, I don't know, speaking up in those situations is really, really difficult. Do you have like thoughts and or things about that in terms of team dynamic? And like I feel like there are certain places where specifically in surgery, like when they do surgery timeouts, where some attendings will be like, look at everyone in the face and say like if you see something that you feel uncomfortable about, like it is your job to say something. Which is really helpful, but in like that's not the norm and that doesn't always happen. So I'm just curious.
Yeah.
Can I speak to this one?
Yes.
Sorry,
Who's
I'm I'm on shift.
Alex, what's up, bro? Yeah, get
What
in here.
Yeah, dude. It's weird to see you dressed so nice. I was like, I assumed you had a court date or something. Yeah, that's like, it's such a hard part of being in like the resident or in the med student role. I think it's, the worst. I also think that's like a hard thing, kind of in the role of being a resident as well, right? Like you're gaining expertise, but you're not yet an expert. And like, I think you're doing OBGYN last I heard, and so you're going to be an expert in that and people are going to ask you for advice in that process. Um, you know, but I think kind of the principles apply to like for everything. And I think a lot of it honestly comes down to like, what's the goal? Like, what are we doing here? Right. And fundamentally the goal of medicine is for the most part to keep people alive. Maybe not all the time, but certainly to like, relieve suffering and kind of all of that. And I think that like, I had one instance when I was on my pediatric ICU rotation as a second year resident that like still haunts me and probably will be one of those cases that like I will remember until I am so demented that I like can't remember anything. And it ended up with like a 14-year-old that died in the PICU because of an airway disaster. And it was the PICU attending and the PICU fellow, and they were the ones taking the airway, and it was like a bloody airway, and they had one tiny suction set up instead of two big ones. Their plan was to paralyze and bag rather than just like, get the, do an RSI. And like I saw all of this happening and I got out the stuff to crite this patient. And I remember like the fellow laughed, thinking that it was like a joke that I had this stuff out. And they were just like so sort of unprepared for it. And yeah, I like really didn't speak up enough. And the airway went terribly. I ended up having to crite this person, but it was like far too late at that point. And I guess for me, like that's something that stuck with me. And it's like that reminder of like, we're here to take care of these people. And like, yeah, we want to like be nice and make friends during it. But like very occasionally in medicine, you might have to tell someone that they're being a jackass and that like, they're making a mistake. And like, I think of it as like a piggy bank thing, right? Like you're going to be in the same hospital for the next several years, you know, like as you're working in the hospital, if you're generally pretty nice, pretty easy to get along with, pretty competent, like it's like putting money in a piggy bank and people trust you, they like you. And so then the occasional moment where, a trauma surgeon is like totally like, just screwing the pooch and like things are going the wrong way, or like, when whatever is happening like that, you have money in the bank so you can be like, hey, you like stop what you're doing. This is a bad idea, like, or we need to do something different. We need to change course. This is going poorly, whatever it may be. And if you've like built those sort of positive relationships where you have trust and generally people like you, I think it's a lot easier to do that. So that for me has been kind of I don't know, the most helpful things. And also, as an emergency medicine doc, like, I'm an attending now, which is awesome, and I have like more respect and more trust, but also like EM docs are, I've worked at 11 hospitals now as an attending, which is far too many. But it's some of them like, were super well respected and trusted. And it's some of them like were really not. And you can really like feel that and tell, based on like where you are. And that'll probably be the same for, if you're OBGYN, wherever you are, anesthesia or whatever you may end up as. And I think like getting that sense early on and then, like figuring out like when you need to push back and when you need to push harder, like when I was working in Utah, like if I called the peds ED or the peds hospitalist or the PICU, like they were listening to what we had to say right away. And at my job in Seattle, like they were way more skeptical of anything we had to say. And so I realized I had to just be a little more aggressive, a little more blunt, channel my inner, East Coast, whatever Ryan's taught me. So, I think a lot of it's about just, yeah, like reading the situation and yeah, putting money in that piggy bank so that when it's time, you can call someone a jackass.
Alex, not to like drag you through this traumatic memory any more than you've already offered, which thank you for sharing the story as the example. Um, is there a moment where is there a specific moment where you wish that you had spoken up and the manner in which you could have, where it would have been successful? Or did you sort of already maximize your potential impact in that situation by having the Crike kit available? And there's not much else a medical student or a resident or anyone besides an attending in the room can do at that point.
Yeah, I mean, it was like my last rotation, my second year of residency, and yeah, it was like this kid had like good pasture syndrome or something, like new hemoptysis, like, totally fresh. And we knew that, and her like oxygen requirements had risen throughout the day. She was at some rural hospital in Utah and then made it to the ER at Primary Children's and then to the ICU. gradually going from nasal cannula to face mask to BiPAP at this point, on like pretty max settings. And so it was like, we know we have to tube this person, and like we knew that there was blood, like she'd had hemoptysis. And so it was like, I was an ER resident, I'm an ER doctor, like we talk about bloody airways until like, the end of time. And so I was like, okay, like, and the fellow was like, oh, I'm going to do this airway because it's going to be a rough one. And I just deferred because there's a PGY-6 fellow, and so I assumed that he knew more than I did. And the reality was like, PGY-6 fellow, like, yeah, he's really smart and knows a ton of stuff, but like they're not dealing with bloody airways very often in the Peds ICU. They're like, if you need like a kid put on ECMO, or if you want to like treat HLH and like talk about like topoisomerase inhibitors, like that's his, ball game, but not this. And so, I mean, the biggest thing that I would like regret not saying is like they had one dinky suction set up, and I was like, "Don't you want something bigger?" And he was like, "Nah, this will be fine." And like I should have just said like, "You want something bigger, and you are wrong." But it was like halfway through this rotation, I'd known this dude for like a week total. I don't want to like rock the boat too much, and I guess I like trusted them, which was anyway. And then, the second moment was when they described their airway plan, which was like, okay, we're going to like push etomidate, we're going to paralyze, and then we're going to bag them. And I was like, you don't bag bloody, like bloody airways is like tube in as quickly as possible. And I like should have said at that point, like, that's a bad plan. That's, like, this is not going to go well. And so then they did it. They like paralyzed, started to bag immediately, like blood started coming out of everywhere. And so the fellow was like, okay, I'm going to take a look. And I remember he like put the glide scope in, and just like, it was just blood immediately on the camera. And so it was just, like going to be a disaster. And then he said, okay, I'm going to come out and we're going to bag. Pulled out, started to bag, couldn't like, could not ventilate for anything. She was starting to desat at that point. So they were like, okay, I'm going to call anesthesia. And it was like, that's not like a viable like that's going to take minutes. This person's going to be dead, before that. And that was finally the point where I like spoke up. I was like, that's like, we don't have time for that. I'm cutting the neck. And then the attending said, no, we're not going to crike this kid. And then I pulled out the knife and I said, I'm cutting you or I'm cutting her. At which point he moved, which was not my proudest moment. But like, I mean, and she arrested within probably 10 seconds at that point. Like she arrested as I was cutting into her neck. Got the airway, but it was sort of too late. At that point, she had a horrible anoxic injury, and family withdrew care a few days later. But I like finally got the courage to speak up, but it was just like far too late. And like, God, like, yeah, you guys like are, well, I guess we got what, one intern in the group, but then everyone else, like, you're all starting residency. Like at the start of residency, I thought I knew nothing. I thought I was like the least knowledgeable person in the room. And in general, there's probably someone in the room that knows more than you about some given topic. But like, there are things that you're going to be experts on, and like, speak up, like, Eric, if you're on your rotation and you see like an airway disaster, like you're the airway guy, like, a lot about airways that maybe a lot of specialties don't. So that's you, and Haley, like when you're an intern, like even 2 months in, like if there's some OB thing when you're on your EM rotation or like whatever, like probably whoever's, like if you're in the ICU or whatever, you probably know more about OB and like gyne stuff generally than they do. So like, don't just say like, well, I'm just an intern. Like you have so much expertise and you have so much value. And like, I'm a generalist. I'm an ER doc. Ryan's an ER doc. And like, odds are when we call someone, like everyone in the hospital probably knows more than we do, probably, could write more book chapters than we do about a lot of stuff. But there are certain things that are our domain. And like, you just have to like, I don't know, have the confidence to remind yourself, like, you are good at the things that you are good at. And like, if someone is telling you something that's wrong, you have to remind them that they're wrong, even if you're an intern, even if you're a generalist. So, yeah.
We had a situation, I wasn't involved in it, but I heard it afterwards where there was a resuscitation happening on the OB floor, and essentially they had an EM intern who was she was like picking up extra shifts because she was trying to get her deliveries, and ended up like really helping out in the situation because she knew more than the, R4 OB, senior. And he was like so happy that she was there and around like when this was happening. And anyway, it was just one of those situations where it was really lovely to see like or hear him have just such humility as well. And hoping that I can keep that with me and everyone else can keep that with them too as they become attendings. So
Yeah, it's a delicate dance. It's really there are the social skills are so much huger in medicine than like any of us realized when we were pre-meds or medical students or residents or starting attending hood. Like the more and more, it's just so much about how you communicate. Alex offered a couple of options for those situations, one of which is to yourself prepare backups. He had a crike in his situation. I don't even know if I can count on one hand. It might have to take two. How many critical procedures were occurring when I was on an off-service rotation where I went and grabbed backup equipment and supplies that the folks doing the procedure had no, like, didn't even have in their head as possibilities. Intubations where like I ran over to the, like before we even started the intubation and like had an appropriately sized LMA and had like a 6.0 tube and a scalpel available and a bougie where like no one else was thinking about these things, but you don't have to be performative about how much you are thinking ahead because you're not like staring down the airway. It's hard to bring yourself back and have 1,000-foot view when you're actually the one where all the spotlights are on. But if you're off to the side and you think of backup plans, start initiating them on your own. The other strategy is you can just like go head on and say what you feel, and it takes a lot of gonads to do that. And you have to really know your shit. But if you know it and you're in that situation, do it. And the worst that happens is you have like overstepped. That's not the worst thing in the world. One of the one of the social strategies is just asking questions. Everyone's expecting you to ask questions. You can politely phrase something as a question such that, if you're truly correct in the situation, answering in a way that affirms the currently incorrect pathway would sound so insane that the person will like catch themselves and correct the behavior before. Um, I think it's a very helpful go-to strategy, but you'll just be recruiting your whole, you know, mass of social experiences every time you're in one of these situations, and you'll get better and better at it. We're coming up on 10 o'clock. I think that was a really fun discussion for me. I enjoyed that. I also like talking about this stuff all the time. I included a snapshot of that like trauma team leadership manual. I think I downloaded the PDF for it when I was in residency. So I can send that along if people are interested. I also mentioned the National Outdoor Leadership School, the Knowles Leadership Curriculum. They have a leadership manual you can buy from their store. It's really good. I leadership, there are like some leadership conferences out there. I went to one run by the Mission Critical Teams Institute. I got something out of it. It's fun to listen to some podcasts. This guy named Dan Dworkis at Stanford has a podcast called The Emergency Mind, where he talks a lot about team dynamics things. Um, One of my mentors in residency really liked listening to FIDNY Pro or Fire Department of New York Pro, and it's kind of an EMS-based podcast, but fire department situation management during crises are very complicated, and some of the principles they talk about do transfer pretty well to medicine and or outside of the hospital. Always open to emails, texts, calls if you guys want to chat more about this stuff or other resources. It's good to see all your faces.